Hi everyone, welcome back to my YouTube channel. In today's video, I will be comparing Global and Professional Direct Contracting or GPDC model with the ACO Realizing Equity, Access and Community Health or REACH model. Let's dive right in. Beginning in 2023, the GPDC model will be redesigned and renamed the ACO REACH model. ACO REACH will enable CMS to test an ACO model that can inform the Medicare Shared Savings Program and future models and includes important changes to the GPDC model in three areas. First is advancing health equity to bring the benefits of accountable care to underserved communities, promoting provider leadership and governance, and protecting beneficiaries in the model with enhanced participant vetting, monitoring, and greater transparency. Now I will compare GPDC with ACO REACH model. As far as goals are concerned, GPDC model's goals are to improve beneficiary access to providers who are personally engaged in their healthcare delivery, to provide strong incentives to improve quality of care by shifting payment away from fee-for-service towards value-based capitated payments. Another goal is to allow organizations with prior ACO experience, innovative organizations taking risk in MA or managed Medicaid, and organizations that focus on complex beneficiary populations to participate. ACO REACH model's goals are to improve the focus on promoting health equity and addressing historical healthcare disparities for underserved communities, continuing the momentum of provider-led organizations participating in risk-based models, and protecting beneficiaries and the model with more participant vetting, monitoring, and greater transparency. As far as timeline is concerned, GPDC model originally consisted of 6 performance years from 2021 through 2026. With ACO REACH model, the policy changes and new name ACO REACH model will take effect at the start of performance year 2023 and continue through performance year 2026. With respect to participants, GPDC model participants are called direct contracting entities or DCEs but are equivalent to ACOs, whereas ACO REACH model participants are referred to as REACH ACOs. When it comes to governance, participating providers in GPDC model generally must hold at least 25% of the governing board voting rights. Each DCE's or direct contracting entity's governing board must include a beneficiary representative and a consumer advocate, though these representatives may be the same person and neither is required to hold voting rights. Now, with ACO REACH model, participating providers generally must hold at least 75% of the governing board voting rights. Each REACH ACO governing board must include a beneficiary representative and a consumer advocate who must hold governing board voting rights and must be different people. In GPDC model, there are no policies explicitly promoting health equity. Whereas with ACO REACH model, there is a requirement for all REACH ACOs to develop a health equity plan that must include identification of health disparities and specific actions intended to mitigate the health disparities identified. ACO REACH model also entails introduction of a health equity benchmark adjustment to better support care delivery and coordination for patients in underserved communities. In ACO REACH model, there is also a requirement for all ACOs to collect beneficiary-reported demographic and social needs data. The ACO REACH model also has a new benefit enhancement to increase the range of services that may be ordered by nurse practitioners to improve access. As far as application for GPDC model is concerned, its participants begin in performance year 2021 or deferred to performance year 2022 due to the public health emergency. Next generation ACOs were able to apply for performance year 2022. Application scoring criteria for GPDC model focused on the following 5 domains: organizational structure, leadership and management, financial plan and risk sharing experience, patient centeredness and beneficiary engagement, and clinical care. For ACO REACH model, application period is opening in spring of 2022 for participation beginning in performance year 2023. New ACO REACH application scoring criteria considers, in addition to the 5 GPDC domains, the following: demonstrated strong track record of direct patient care, demonstrated record of serving historically underserved communities with positive quality outcomes, program integrity risk posed by REACH ACO ownership / parent companies. GPDC participants must agree to meet all the ACO REACH requirements by January 1st of 2023 in order to continue participating in ACO REACH. With GPDC model, global DCEs or direct contracting entities receive 100% of gross savings / losses. A discount is applied to the benchmark before gross savings / losses are calculated, which helps guarantee shared savings for CMS. There is no discount for professional DCEs. You can see the original discount levels originally planned for the benchmarks of global DCEs in the table below. With ACO REACH model, reduced discount rate for global ACOs to 3 to 3.5% beginning in performance year 2023 will further CMS's goal of increasing participation in full risk FFS or fee-for-service initiatives. When it comes to quality withhold for GPDC model, the quality withhold applied to the benchmarks of both professional DCEs and global DCEs is 5%, whereas with ACO REACH model, quality withhold for both professional ACOs and global ACOs is reduced to 2%. When it comes to risk adjustment, in GPDC model, two policies protect against risk coding growth. First is the coding intensity factor or CIF limits risk score growth across the entire model. The CIF or coding intensity factor applies to all direct contracting entities to limit risk score growth to the average prior to the start of the model. The other one is risk score growth cap, which limits the direct contracting entities or DCEs risk score growth to ±3% over a 2-year period. The DCE specific caps on overcoding ensure DCEs are coding appropriately and limit gaming. In ACO REACH model, two changes to the risk score growth cap further mitigate potential inappropriate risk score gains. Adopt a static reference year population for the remainder of the model performance period. Cap the REACH ACO's risk score growth relative to the DCE's demographic risk score growth, so the ±3% cap is appropriately adjusted based on demographic changes in the underlying population over time. Currently, risk score cap is based on HCC growth. This would cap HCC growth relative to demographic growth. Next on the list is monitoring / compliance. In GPDC model, robust monitoring of all direct contracting entities includes monitoring for levels of care provided, compliance audits conducted throughout the year, investigation of beneficiary complaints, and collection of beneficiary surveys or CAHPS annually to measure changes in beneficiary satisfaction. Whereas with ACO REACH model, additional monitoring and compliance efforts and analytics will assess annually whether beneficiaries are being shifted into or out of Medicare Advantage or MA, examine ACO's risk score growth to identify inappropriate coding practices, monitor for non-compliance with prohibitions against anti-competitive behavior and misuse of beneficiary data. Benefits of GPDC and ACO REACH model, which apply to all performance years of the model, include a higher quality of care and greater clinical support and care coordination for beneficiaries, benefit enhancements, and beneficiary engagement incentives offered under the model, for example, telehealth, post-discharge home visits, and waiver of the homebound requirement, Part B cost sharing support, concurrent care for beneficiaries that elect hospice care. Beneficiary protections, which apply to all performance years of the model, entail that all aligned beneficiaries retain full original Medicare benefits and can see any Medicare physician. Beneficiaries are proactively notified on an annual basis of their alignment to a DCE/ACO and that their benefits have not changed. Beneficiaries retain all fee-for-service Medicare channels for raising concerns or reporting complaints. This brings us to the end of my presentation. Hope you found this information useful. If you enjoyed this video, please consider subscribing to my channel. Thank you for watching. Bye now.